We would like to thank Alexion Pharmaceuticals, argenx, Horizon Therapeutics, Janssen Pharmaceuticals, Regeneron, and UCB for their generous support of this symposium.
So it is now my pleasure to introduce our first session, Providing Critical Care to the Myasthenia Patient, presented by Dr. Peter Abdelmalik, a neurointensivist at University at Buffalo. As a neurointensivist, Dr. Abdelmalik provides comprehensive care to patients in the neurological intensive care unit who have sustained serious neurological injuries. These include stroke, intracranial hemorrhage, traumatic brain injury, prolonged seizures, infection, severe neuromuscular disease, or spinal cord injury. Dr. Abdelmalik focuses on ensuring optimal function of his patients, supporting organs such as the heart, lungs, and kidneys. By doing so, he mitigates his patients' potential for secondary injuries and facilitates their neurological recovery. Dr. Abdelmalik, thank you so much for being here today. We will now turn the time over to you.
Thank you, Marissa, and thank you to the organizers of the symposium for inviting me to speak. I actually don't get a lot of opportunities to speak to sort of a lay audience. So I thought it would be a great opportunity for me to discuss this in a community of potential patients. I wanted to keep it high level, keep it interesting, but certainly keep it digestible. And please feel free to enter all the questions in the chat and any feedback with regards to the level of content today. Thank you, Marissa, for the great introduction. As she mentioned, I am an ICU doctor, and so I don't see a lot of myasthenia patients in general, but when I do see them, typically it's an emergency or a pending emergency. So let's dive right in. I don't have any disclosures or conflicts of interest. And so before we dive in, I just wanted to define what is critical care, because, critical care, intensive care, these terms get bandied about quite a bit. And the definition is not always sort of understood. And so there's a very nice definition from the US Centers of Medicare and Medicaid. And they state the following: a critical illness or injury acutely impairs one or more vital organ systems, such that there's a high probability of imminent or life-threatening deterioration in the patient's condition. Critical care involves high complexity decision-making to assess, manipulate, and support vital organ system functions, to treat a single or multiple vital organ system failure, and to prevent further life-threatening deterioration. And these systems include the brain, the heart, the kidneys, and importantly for us, the lungs for today's discussion. So as an overview, I wanted to put on a hat of a pulmonologist. I am a neurologist by training, and I work predominantly in the ICU, but I'm going to do my best to recap the salient features of basic lung anatomy and physiology as it relates to neuromuscular disease, including myasthenia gravis. I'd like to just recap the history of positive pressure ventilation and the birth of really ICUs in the history of medicine. And then we'll discuss the assessment and treatment of the myasthenic patient who may need critical care.
Dr. Abdelmalik, I'm sorry to interrupt you. We can't see your slides. I don't know if you're showing slides, but.
Oh, I'm sorry.
That's okay.
Is that better?
There you go. Thank you.
Okay. Sorry about that. So we defined critical care thus far. And then these were the objectives to review. We're just going to review some basic lung anatomy and physiology, and particularly as it relates to neuromuscular disease and specifically myasthenia gravis. We were going to review the history of positive pressure ventilation, and really the birth of intensive care is essentially in the history of medicine, and then go on to discuss the assessment and treatment of the myasthenic patient who may need critical care. So when we talk about the lungs, there's a number of ways that we can sort of attack. What you see in the upper right is a chest X-ray, and below that is a CT scan. The difference between a CT scan and a chest X-ray is really the resolution. They use the same technology, essentially, of X-ray radiation. The CT scans gives you several slices, and so you can build a three-dimensional model. But the chest X-ray gives you a wealth of information as well when you know how to look at it correctly. Of course, we know we have two lungs, generally speaking. And the blood returns to the right side of the heart and goes through the lungs and then returns to the left side of the heart to go to the rest of the body. And the function of the lungs primarily are to bring in oxygen and to waste carbon dioxide. The carbon dioxide is a byproduct of cellular respiration and what the cells are doing at a microscopic level. Not really illustrated here, but also the objective of the respiratory system, not necessarily the lungs themselves, but the tubing and the muscles to bring the air in to the lungs so that they can participate in this gas exchange. And we'll explore that a little further. Of course, secondary functions of the lungs that we're not going to talk about include heat dissipation. So, when it's hot, you tend to breathe faster. Also, when you're febrile, you tend to breathe faster. If you have acid-base dysregulation, the pattern of your breathing may change. It also has some endocrine or hormone regulation, BP, blood pressure regulation, and it's also involved in drug metabolism and clearance of certain metabolites. For example, if you're on a ketogenic diet, your breath may smell fruity, and that's because the acetone is one of the waste products. So here's a nice cartoon that I found online of the respiratory system in action. As I mentioned, I hope you guys can see my pointer there. A big part of it is bringing the air in through the nose or through the mouth, through the pharynx, the larynx, into the trachea, and ultimately into the lungs. And you can think of those as basically a system of tubes. For what's important at the bottom of the lungs, or the endpoint are these alveoli, these kind of grape-like structures that participate in gas exchange. So the oxygen is going to dissolve in to the bloodstream, and the carbon dioxide is going to dissolve out into the balloon structures where the carbon dioxide is ultimately exhaled. What's important to know is really the muscles that are involved in respiration. When we take a breath at rest, and that's important because the physiology changes when we're exercising or when we're sick. Really, there's only one muscle involved, and that's the diaphragm, and that's this flat muscle that you see here at the bottom. And so when we want to take a deep breath in, our brain sends a signal down to the diaphragm, and what it does is it moves downward, and what that does is it enlarges the chest cavity and creates a negative pressure space that in turn expands the lungs, and the airways themselves have a negative pressure, and the air is forced to come inward because of the negative pressure. When the muscle relaxes, the chest cavity contracts, and that causes a positive pressure, and exhalation in general is a passive process. When it's at rest and there's no disease process involved, expiration is very much a passive process. So just to recap, at rest, inspiration really involves the diaphragm, which is the main muscle. It brings the chest cavity down and expands the rib cage. It creates a negative pressure scenario where air comes in from the atmosphere into the negative pressure. In general, air wants to go from high pressure to low pressure. And so the air is able to enter into the lungs through the system of tubes that we discussed, and ultimately down to these grape-like structures called the alveoli, where gas exchange takes place. And then the relaxation of the diaphragm is a passive process, and the chest wall contracts, the lungs have positive pressure. Basically, that's how we exhale the carbon dioxide gas. As I mentioned, that's the physiology at rest. When we're exercising or when we're sick, we have to engage some of the other muscles for inspiration. And some of those muscles are listed up here in the right-hand corner. You can see, not important for our purposes where these muscles are here, but there's a number of other muscles that can participate. But when you see someone who's using these muscles for inspiration, you know that there's something that's not right. They're out of breath, or they're having some sort of problems at a muscular level, essentially, and particularly important for the myasthenic patient, because we know myasthenia is a neuromuscular disease, and we'll touch on that a little bit more. But essentially, it's the failure of the muscles to work, and in this case, the main muscle is the diaphragm. The diaphragm does 60 to 80% of the respiratory work breathing. And so when we have problems with the diaphragm, we have to engage in other muscles. But ultimately, myasthenia is not a dysfunction of one muscle, but in several muscles. And so the whole system is susceptible to breakdown when we have a myasthenic crisis. And we'll talk about that a little bit more. As I mentioned, exhalation is a passive process, but again, when there's a disease process or when we're exercising or when we're sick, we engage in other muscles. And the secondary muscles of expiration include the muscles of the abdomen, which I didn't detail there, but the rectus abdominis and the transverse abdominis muscles. And again, when you look at someone and you can see that they're engaging a lot of their abdominal muscles, you can know that there's something not right, something is awry. And so when we're talking about respiratory physiology, it's important to define some terms. And these terms are important because they're going to help us later on in our discussion. And so it's a little bit of dry material, but I wanted to sort of lay the groundwork, lay the foundation for our later discussion. So when we talk about lung volumes and respiratory physiology, there's several terms that we need to know. One is the tidal volume. And that's basically the volume of air that we inspire and expire when we're at rest. The expiratory reserve volume is the volume of forceful expiration after a tidal volume. And so basically, if we forcefully expire all the air in our lungs that we can, that volume of air is the expiratory reserve volume. Conversely, the inspiratory reserve volume is the amount of air that we can take in over and above the tidal volume. So if we take a deep breath after we've taken a tidal volume and try to fill our lungs as much as we can, that volume is the inspiratory reserve volume. Then there's the vital capacity, and that's basically the sum of the tidal volume, the expiratory volume, and the tidal volume, the expiratory volume, and the inspiratory volume. So it's the sum of all three volumes. And lastly, there's something called the residual volume, and that's basically the amount of air that remains in the lungs even after we exhale all the air that we can. And that residual volume is important to keep those alveoli, those grape-like structures, open, because if they collapse, they're no longer available to exchange gas, to take in the oxygen and to breathe out the carbon dioxide. So that residual volume is very important. And so this is just a diagram to illustrate the volumes. And if you go see a lung doctor, he or she may do what's called a spirogram or a pulmonary function test in his or her office. And that's really to measure these volumes. And so as we discussed earlier, tidal volume is the amount you breathe in and the amount you breathe out at rest. If you have your inspiratory reserve volume is if you take, after tidal volume, you take the biggest breath that you can, and then you exhale it. And of course, if you exhale all the air that you can, you have your expiratory reserve volume. And as I mentioned, the vital capacity is the sum of all three volumes there. The residual volume is what remains after you've exhaled all the air that you can out of the lungs. And so this is just to recap what we discussed so far. At rest, inspiration is active and expiration is passive. The most important muscle of inspiration is the diaphragm. The diaphragm contraction forces the abdominal contents downward and forward and basically increases the size of the chest cavity. And the lungs are adherent to the chest wall. And so when the lung expands, when the chest expands, the lung sort of follows suit because of the negative pressure that's there. And in general, the diaphragm, which I didn't mention earlier, the diaphragm is composed of both slow twitch and fast twitch muscle fibers, and generally is very resistant to fatigability, which is why, let's say, if you're running a marathon, you never have, you can feel fatigue and lactic acid in your leg muscles, for example, but it's virtually unheard of to have that type of lactic acidosis built up in your diaphragm. And as we discussed, accessory muscles are important for rapid breathing, and also they're important for coughing and the clearance of secretions, which can be certainly important when we think about myasthenia gravis and what's called bulbar weakness. Bulbar weakness is a term neurologists like to use to encompass all of the muscles of sort of the face, including the pharynx, the tongue, and the eyes as well. All the muscles that kind of stem from the brainstem are called the bulbar muscles. One thing I didn't mention is your minute ventilation includes your tidal volume times your respiratory rate. And so as you can imagine, let's say that we're a myasthenia patient and we're having problems breathing, our diaphragm is not going to be working as efficiently. And so our tidal volume is going to decrease. But in order to maintain a stable minute ventilation, our respiratory rate has to increase. And so what you can notice, somebody who's having problems breathing, initially they'll just compensate, and they'll be able to compensate by breathing a little faster. And like I said, engaging those accessory muscles as well. And of course, those bulbar muscles are important for protecting our airway, clearing our throat, and making sure that we don't aspirate our oral contents, our saliva, which includes a lot of bacteria that are not safe, that are safe in our mouth, but are not safe when they enter the lungs and can cause problems, including inflammation and potential infection. So that was just a little bit of an overview of basic pulmonary anatomy and physiology. I wanted to change gears here and just talk about critical care and the history of neuromuscular weakness. In general, respiratory failure remains the most common cause for admission to the ICU in patients with neuromuscular disorders. And over the last decade or so, ICU treatment has decreased the mortality from myasthenia gravis from 50% to approximately 5%. Depending on who you read, mortality can range anywhere between 5 and 20%, and we'll talk about that in the later slides. But certainly there's been a huge improvement in the prognosis of myasthenia gravis, and a lot of that comes from early recognition of impending myasthenic crisis. And so when we look at the history of mechanical ventilation, it starts in 1543 in Belgium, where an anatomist named Andreas Vesalius noted in his animal experiments that if you cut a hole in the animal's trachea and took some type of tube, like a reed or a straw, you can blow into it and basically make the lungs and the chest cavity open up, and the lungs would take air and rise again. Since that time, throughout the 1800s, there was all sorts of contraptions to try to take over the work of breathing. A lot of these were termed, had different terms. One of them is the iron lung, essentially. And so you had this box that you generated a negative pressure into, and that negative pressure pulled on the chest wall to open up the chest wall and basically created a negative pressure gradient within the lungs, where the air could enter into the lungs and participate into the gas exchange. One of the first ones was invented in 1864, as you see here. And of course, there was very elaborate variations on the theme. What you see here is a negative pressure room, where a patient who needs mechanical ventilation is in the room. A bunch of pistons work to generate a negative pressure. And whenever the patient needs nursing care, the nurse is able to come to the bedside here. Of course, the pressures have to be reoriented, but essentially, this was the state in the early 1900s, late 1800s. Really, it was the 1950s that really brought about progress in mechanical ventilation. At that time, polio was a public health pandemic. For those of you who don't know, polio is a neuromuscular disease that affects the anterior horn cells of the spinal cord. And so very similar to other neuromuscular diseases, respiratory failure is a big problem. Although it wasn't initially understood at that time, it took an anesthesiologist by the name of Bjorn Ibsen, who hypothesized that the mortality was due to respiratory failure. And essentially what he did was he put a small hole in the trachea of these patients. And of course, there was no machines that could breathe at that time. And so they had to be handbagged, essentially. If you've ever seen an ambu bag, those blue bags that are able to, if you squeeze them, they're able to give air to patients. And thus was born the era of positive pressure ventilation. And we'll talk about that a little bit more. And so this is a graph here from the time of polio. You can see the mortality drastically decrease once the patients have received a tracheostomy and positive pressure ventilation. That's there. And this is a picture that you might have seen previously if a patient's in the ICU and they need mechanical ventilation. This is the kind of contraption that you might see. The patient has a tube that's inserted through their mouth most often. It can be inserted into their nose, depending on the clinical scenario. And ultimately, the machine delivers a positive, basically pushes a gust of air into the lungs. The tube is inserted into the trachea, essentially, and then from there, that air from the machine goes into both lungs and through a one-way circuit here, and then it comes out through a valve and an exhaled circuit there. The air is humidified, it's warmed, and the operator can change a bunch of pressures, look at volumes, and look at the fraction of inspired oxygen as needed for the patient. And of course, today, there's a bunch of machines on the market that utilize the idea of positive pressure ventilation, but they're not as invasive. And some of you may be familiar with CPAP, or continuous pressure ventilation, or BiPAP, where it's two various pressure. You can set two various pressures, and essentially it's the same idea. However, in these scenarios, it's not as invasive, i.e., there's not a tube that needs to be inserted through the patient's mouth, through their larynx and their voice box down into the trachea, but rather the patient wears a simple face mask, or newer, more recently, there's all sorts of nasal variants or nasal pillows or nasal masks, essentially, that are more comfortable, where the patient receives this positive pressure ventilation. And of course, still a mainstay of ICU care is the mechanical ventilation, as we discussed previously, where the tube is inserted in through the trachea, and the machine delivers the breath this way. So with that in mind, and having recapped the normal physiology of the lungs and some of the tools that we have in critical care to help out patients with neuromuscular respiratory failure, let's take a look more at the patient with the myasthenic crisis. So I don't know how much you guys know or what you guys are going to hear about with in general myasthenia. I thought I'd put a slide in just as an overview. I'm sure you guys are going to, I have Gil Wolfe speaking after me, who's an expert in the field, and certainly I'm sure he's going to go over these things. But for the sake of completeness, I decided to put the slide in here. In general, myasthenia gravis is an autoimmune disorder, and it's B-cell mediated. And in general, for most patients, they have receptors that attack their acetylcholine receptor antibodies. They have antibodies directed at the acetylcholine receptors on the postsynaptic neuromuscular junction. Essentially, what that means in lay terms is that these antibodies prevent the neurotransmitter from the nerve to activate the muscle so that the muscle can contract, essentially. Prevalence is anywhere between 40 and 180 million people worldwide. And depending on who you read, annual incidence is between 4 and 12 cases per million. It's important to note that there's a bimodal distribution. It can affect both older people and younger people. In general, it affects younger women and older men, but that's just a generalization, and it can certainly affect both sexes at any age. As I mentioned, the majority of patients have antibodies against the acetylcholine receptor. But then there's a few that have some variations, and as our technology and molecular biology improve, we're able to identify and isolate some of these more rarer variants. Not that rare, but of those who don't have antibody, if the initial testing for acetylcholine receptor antibody is negative, but half of those have what's called or have antibodies against what's called MuSK, which is a muscle-specific tyrosine kinase, basically involved downstream from when acetylcholine binds to the acetylcholine receptor. So it's still involved in the process of depolarizing muscle for contraction. And of course, another one that's recently been isolated includes the LRP protein. And in some patients, of those, 1/4 of those without acetylcholine receptor antibody negative, of those about 25 never have an antibody identified. And in those patients, often they rely on EMG and nerve conduction studies to help with the diagnosis. And of course, some patients have a thymoma, which is a residual gland in the chest. and there's certain antibodies that are associated with that. And of course, if we remove that thymoma, patients can have a very good outcome. And Dr. Gil Wolfe is an expert in that, and I'll leave that to him. This is just to put in chart form what we just discussed. As I mentioned, myasthenia is both early onset and late onset, and the most common cause is acetylcholine receptor antibodies. In general, however, there's some other more rarer antibodies that are more recently being isolated, including the MuSK and the LRP. Specific to MuSK, it bears to, or it's important to note that patients with MuSK often have bulbar weakness. And so, as I mentioned previously, weakness of the tongue, the pharynx, the soft palate, excuse me, and the eyes and the upper neck muscles. And all of those are important for breathing and for protecting our airway, protecting the respiratory system from aspiration. And so as an ICU doctor, when a myasthenia patient is an extremis, more often than not, they may be MuSK positive patients. And so when we define the myasthenic crisis, myasthenia in general is complicated by, defining the myasthenic crisis, it's a myasthenic patient that has a need for, essentially positive pressure ventilation, as we discussed, due to the weakness in the respiratory muscles, more specifically the diaphragm. In general, the diagnosis of myasthenia is known, but there are a handful of patients that present without a known diagnosis of myasthenia, and this is the first presentation of impending respiratory failure. Crisis is most common within the first few years after diagnosis, and in general, it doesn't come out of the blue. If you take the time to elicit the history, you can tell that the patient has had some worsening of symptoms for some time. Whether or not it was recognized or not is another issue. In general, as some of you may know who might be myasthenic patients, in general, there's usually a stressor that brings out the exacerbation or the crises. These types of stresses include, acute illness type of sort of a pneumonia or either a viral pneumonia or bacterial pneumonia, having had surgery and having undergone anesthesia, and also certain medications, which is why it's always, crucial to discuss with your primary care doctor that you have the diagnosis of myasthenia, because there's a multitude of medicines that have been involved in exacerbating myasthenia. This is by no means an exhaustive list. What you can see, however, a lot of these are antibiotics, and so it's always a conundrum when myasthenia patients have a urinary tract infection or have a pneumonia of some kind. The antibiotics are usually prescribed with great hesitancy and great caution because of the fear of exacerbating the symptoms. Moreover, you can see some other very common medications, including statins and beta blockers, which particularly in older patients, they more likely than not may be on. And you'll also note that corticosteroids are on the list here. And of course, some of you may know that corticosteroids are one of the mainstay treatments. And so it's sort of contradictory that a medicine that can help with myasthenia can also exacerbate the symptoms. But sure enough, they can initially exacerbate the symptoms before their effect on the immune system kicks in, essentially. And so when I'm asked to see a patient at the bedside, what are some things that I look for? If a patient is admitted to the hospital and I'm being asked to evaluate for an ICU admission, often muscle weakness is evident, but I often look at the neck muscles particularly, so their ability to, push my hand with their head forward and backwards, because that also is an indirect measure of their bulbar weakness. Testing their arm and leg strength is important, but not as important from the standpoint of ICU admission. And of course, myasthenia is primarily involves the eyes in the majority of cases. And so, it's having eye issues, including double vision and a skew deviation or a disconjugate gaze, meaning that your eyes aren't necessarily lined up exactly, is a very sensitive marker for myasthenia. Additionally, if they have eyelid drooping or ptosis, another very sensitive marker for myasthenia. Your doctor may test your ptosis or stress your ptosis by having you look up for a minute or more. And if you don't have ptosis and you look up for a minute, in general, if you have myasthenia, you should develop ptosis at that time. Another trick is to have you count from 1 to 50, excuse me, count from 1 to 50 and see your ability to articulate after that, because what we've done is fatigued your bulbar muscles, again, the muscles of your tongue, your mouth, the soft palate. And by definition, myasthenia is known as a fatigable weakness. So it should get worse as you use those muscles. But as a, to circle back as an ICU doctor, I really want to test those bulbar muscles, and those are the muscles that I'm most interested in. And of course, the indirect muscles of the diaphragm. And so seeing if the patient can count from 1 to 20 with a single breath is a sort of quick evaluation at the bedside. If they're breathing, having trouble breathing, if I see the accessory muscle use, if they have a staccato speech, meaning that they can't finish a sentence in one breath, as I mentioned, counting from 1 to 20, also important. And then there's some other things too, like seeing how strong their bite is by putting a tongue depressor, and seeing how strong their jaws, their muscles in their jaw, their muscles of mastication can contract to hold that tongue depressor in place. But ultimately, a lot of these tools are helpful, but sometimes, as I mentioned, you can just look at the patient and look at the way they're breathing and their use of respiratory muscles, and you can sort of make your diagnosis from there. The last here is the abdominal paradox. As we discussed in general, the abdominal muscles are used for expiration, and in general, they should come in when you breathe in. So sorry, usually when you breathe in, your chest expands and your belly expands kind of in unison, because the diaphragm is moving downward, moving the abdominal contents, your colon, your stomach, etc. And so the belly expands to sort of make space. When a patient is an extremis, sometimes they have what's called paradoxical abdominal breathing, meaning that their belly goes in when their chest comes out, and this is on inspiration. And so that's a paradoxical movement. Again, a quick bedside assessment can tell me that. And all these are signs that we sort of synthesize together to make an assessment of whether or not the patient's going to have issues. And so, the next step, if I'm worried about a patient, would be to run some tests. But as I said, in general, your clinical suspicion is driven by how a patient looks and how their work of breathing, essentially. Nevertheless, it's prudent to rule out some other issues or other causes of respiratory failure. So that's where your chest X-ray may help you to diagnose a pneumonia, for example, or to diagnose a lung collapse. If you're collapsed on one side, you're going to have all of those signs of respiratory distress using accessory muscles and so forth, but it may or may not be related to the myasthenia or the neuromuscular disease that a particular patient has. An arterial blood gas, or also known as an ABG, is helpful to measure the partial pressures of oxygen and carbon dioxide in the blood. Now, what's important, and what I tell a lot of my trainees, is that if you have a normal carbon dioxide, but the patient is breathing quite fast, you have a problem, because in general, if you're breathing fast, you should have a low carbon dioxide. And so if you're breathing fast and you have a normal carbon dioxide, it really suggests that there's there's a huge inefficiency at work, and there's an impending problem. Of course, if you're down to where your oxygen level is of concern, then it's already too late, and the process is well underway. And so if you're waiting for the oxygen level to decrease, it's not a very sensitive marker, and you're sort of behind the 8 ball at that time. More recently, ultrasound has gained quite a bit of use in ICUs in general and at the bedside, and it's very good for looking at the diaphragm. Its thickness, like any other muscle, when it contracts, its thickness changes, and you can assess that thickness. And also you can assess the travel, excursion of travel and sort of have a surrogate of its function at that time. But probably one of the best tests is the bedside pulmonary function test, which we usually have a respiratory therapist do with the patient at the bedside. These are similar to the pulmonary function test that we described and we defined earlier, with a slight nuance because we don't have the same tools available to us when the patient is in hospital. And so this is just to summarize what we've discussed so far. This is a nice chart from the group at Mayo Clinic in Rochester. When you suspect a patient has a myasthenic exacerbation, you really can triage them into mild or moderate weakness or severe weakness. And, you know, if they're warranting admission to the ICU, most likely they'd be in this column here with severe weakness. And of course, one of the most important things is to evaluate their bulbar function and if they're at risk for aspiration. As I mentioned, aspiration is a hugely important thing that we want to avoid at all costs, because anytime that you have aspiration, you risk inflammatory reaction in the lungs, you risk a pneumonia, and that would add significant morbidity and mortality risk to any type of myasthenic problem that you already have. And so we are vigilant in looking for aspiration and guarding against it. If there's some concern for aspiration, then the patient should be intubated immediately and started on immunotherapy. If there's no bulbar dysfunction, however, the patient is in respiratory distress, you really look for other signs of hypercapnia, as I mentioned, elevated CO2. And so if there's elevated CO2, then yeah, you should intubate. But if there's not elevated CO2, then you can use a bridge called the BiPAP, as we discussed earlier, that base mask to give positive pressure and help the patient with their work of breathing. And so this is just to reiterate the use of the BiPAP, because it's a great tool. You know, nobody wants to have a breathing tube down their throat and be put to sleep, and certainly there are risks involved with it as well. And so it shouldn't be taken lightly. And so I like to use the BiPAP whenever I can for patients, particularly when you know, if you identify the patients early enough, you're able to use it, and it's quite good at being a bridge to avoid intubation and mechanical ventilation. In general, when it's been studied in a systematic fashion, it decreases the need for intubation and decreases the length of stay in the ICU. Having said that, however, if you have significant bulbar weakness and respiratory failure, which can be demonstrated with a higher carbon dioxide or a low oxygenation, then you should be intubated and have mechanical ventilation or have the machine breathe for you. Just a note here for anesthesia, because you do need to be anesthetized at least initially when you have that breathing tube placed, in order to relax the muscles of the pharynx and the larynx, in order to get a good look and place that breathing tube through the vocal cords. And so you need some sedating medicine, but also in many cases you're going to need a paralytic or a muscle relaxer. And so because your muscles are already sort of dysfunctional in myasthenia, the anesthesiologist or the ICU doctor who's going to administer those medicines needs to be aware of those and really decrease the dose. Otherwise, you're going to have basically a very long, protracted muscle weakness because of overdose of that particular medicine. Initially, it's important to know that once that breathing tube goes in, it's usually very difficult to wean the mechanical ventilator because of the disease process. And it's not uncommon for the medical team to try to take out the breathing tube and the patient to have some difficulty and needing that breathing tube replaced for an additional length of time. Which is all the more reason is, you know, if we're able to avoid that breathing tube in the first place with the BiPAP machine, it's really the most ideal scenario. And so just to go back to evaluating the patient, you know, we had the chest X-ray, the ABG, but one of the most important things is the bedside pulmonary function test, because this is really a quantitative measure. This is what I can put in paper to define or to justify my actions. I might have a certain sense of whether a patient's going to do well or do poorly, but that's really a subjective impression. Whereas when I have the respiratory therapist document these particular findings, it gives a a number that I can sort of lean on in a foundation for the next steps in the management of the patient. So in general, as we discussed before, the vital capacity, which if you recall was the tidal volume in addition to the inspiratory reserve volume and the expiratory reserve volume. In general, they should be greater than 20 cc's per kg, and that's for of ideal body weight. And it's important to know that. Another unit of measure that we can do at the bedside in the hospital is called the negative inspiratory pressure, which is basically how the force with which you can suck through a straw. And so that could be measured easily at the bedside. And the magic number there is less than 30, or it should be actually greater than minus 30, because you want to generate a force of minus 30 or less, if that makes sense. And then basically exhaling through the straw, you want to generate a pressure greater than 40 centimeters of water. And so those would numbers that would be generally reassuring. Conversely, if you didn't meet those criteria, those would generally be numbers that would be concerning and warrant, intubation and mechanical ventilation. And of course, certain people are bigger, athletes have a greater vital capacity. And so they may not, they may have a higher sort of residual. And so you also want to know what is the change from the baseline. And so, they may not meet these criteria, but if we're greater than a third decrease in any of these numbers, we really should consider intubation and mechanical ventilation. What's important is that these tests, these pulmonary function tests, are non-invasive, and they can be done at the bedside, and they can be repeated several times in a day. And so really helpful to put a score, to put a number on how well a patient's or how poorly a patient's doing to help to guide therapy. Excuse me. And so once we've decided that the patient is in myasthenic crisis, as we discussed previously, not only do we have to manage their airway, manage their lung function, we have to treat them. And so the mainstay of treatment for a myasthenic crisis, and generally two medicines that have been studied in comparison and are both relatively equal in their efficacy, that being intravenous immunoglobulin, also known as IVIG, and plasmapheresis. IVIG is essentially just pooled immunoglobulin or pooled protein from donors, and that's given to patients. In general, it's relatively safe and maybe safer in older patients with multiple comorbidities. However, there are some risks. Risks include thrombosis or blood clotting. And so any patient that's had a previous blood clot, including a DVT, a PE, or a myocardial infarction or a stroke, the use of IVIG has to be reconsidered. Additionally, because there's a huge increase in protein that's circulating through the bloodstream, there's a risk of kidney failure. Plasmapheresis is sort of similar to dialysis in that you're hooked up to a machine that filters out a lot of the soluble protein in the bloodstream. And so not only does a lot of the protein is pheresed out or washed out, and then you get donor protein to replace a lot of your factors. However, there is a risk for bleeding because some of those factors may not be replaced. Some of the factors important for clotting of blood, clotting of bleeding. There's a risk for blood pressure variations and hypotension. And there's always a risk for sepsis with plasmapheresis. Additionally, in order to get plasmapheresis or to undergo plasmapheresis, it requires the insertion of a central venous catheter, generally in your neck, under your collarbone, or in your groin. And there's a sort of risk associated with that as well. And so the medical team and the patient may favor one or the other. In general, it's been documented that plasmapheresis may have a more rapid effect. And so, but there is the cost of, or the need of having to place a central venous catheter up front. And as I mentioned, in general, strictly speaking, they're equal in efficacy, and there's no indication that one is necessarily better than the other. And of course, the second arm of treatment for myasthenic crisis includes steroids. All patients with myasthenia crisis should receive steroids. Oh, sorry about the typo there. Generally, 0.5 to 1 milligram per kilogram of ideal body weight is the dose. As we discussed earlier, the steroids may worsen the myasthenic crisis, at least initially, and that's something to bear in mind. And the steroids often manifest, their therapeutic effects often manifest a couple of weeks after. And the third arm of myasthenia crisis includes steroid-sparing agents, often azathioprine is used in combination with steroids, which is first-line therapy. I won't go too much into this slide. I'm sure you're going to have other speakers, including Dr. Wolfe, go into this. But essentially, it's important to have this steroid-sparing agent because of the side effects of prolonged steroid use, including osteoporosis, glucose, hyperglycemia, and bone necrosis, that type of thing. So I'll leave that slide there. And overall prognosis, as I mentioned, depending on who you read, the mortality of myasthenia crisis can be anywhere from 5 to 20%. It depends on the population studied. As we discussed earlier, there's two populations generally, or bimodal distribution. There's younger patients who tend to do well in a myasthenia crisis, and of course the older patients who tend to do more poorly. The most common cause of death in patients with myasthenia crisis is usually sepsis and multi-organ failure. And so, as we discussed earlier, the role of aspiration and having a pneumonia certainly plays a role there in being the cause of sepsis. Another cause of morbidity is prolonged mechanical ventilation and the need for a tracheostomy, a hole in the throat, and that is approximately 20%. And risk factors for prolonged mechanical ventilation includes being older, having a pneumonia, and having late onset myasthenia gravis. So overall, in our 50 minutes or so, we discussed the basic anatomy and physiology of the lungs, the importance of the diaphragm in terms of inspiration, and some of the accessory muscles that are used in exercise and in disease states. We looked at the history of ICUs and positive pressure ventilation, and we touched on some of the salient points of myasthenia crisis, how to evaluate the patient at the bedside, and how to treat them. Happy to take any questions. I have about 5 to 10 minutes left, I think, and certainly open for discussion.
Thank you so much, Dr. Abdelmalik. Great presentation. It looks like we do have a couple of questions. In the chat here, it says, when doing a single breath count, what is the rate of speech, fast or normal, that should be used?
So great question. It hasn't been sort of thoroughly studied in that way. When someone if a myasthenic patient is breathless, the faster they speak, the quicker they're going to run out of breath, essentially. And so, if they try to take that shortcut, I think it's going to catch up to them.
And another question came in. What is the difference between this and OPMD? I believe it's asking what's the difference.
Neuromuscular dystrophy is so that is oropharyngeal muscular dystrophy is a neuromuscular disease that doesn't necessarily affect the transmission, the synaptic transmission from nerve to muscle. Well, I guess the end result I think is similar, but the underlying physiology is different. And so, without getting into the weeds of it, you're absolutely right. The presentation can be very similar. Weakness in the bulbar muscles, particularly, can be very similar. But the difference is really in the treatments and the prognosis.
Great. And just a reminder to everybody, if you have a question, feel free to type it into the chat. You can find it at the bottom right hand of your screen. We'll give everybody just a second. One of the questions that I've heard before, Dr. Abdelmalik, is people coming into like an emergency room situation in distress, and the emergency room physicians maybe don't know as much about myasthenia gravis. Is there anything that patients can do to kind of help in that situation, or I'm not really sure what the question is, just kind of a comment though of what can people do when that happens?
Well, familiarizing yourself with the list, not necessarily for the ER, but engaging with your primary care doctor, knowing that list of medicines that can exacerbate myasthenia is certainly important because it's a big list, and primary care doctors are overworked, they're busy, and it may slip their mind. And so you may be getting a medicine for pneumonia or urinary tract infection, but it's important to sort of alert them and be familiar with the medicines that are on that list because it's an extensive list. With regards to presenting to the ER, I think basically with the tools that we discuss and the signs that we discuss now, I think you should be able to get a sense of what a crisis looks like, and any astute ER doctor would be able to recognize it. But maybe if they're new or they don't have a lot of experience, just knowing that you have the diagnosis and you have the signs of respiratory compromise and alerting them to that, I think could be prudent.
Great. And yes, somebody, my colleague shared in the chat that MDA actually has an emergency room alert card that we've created that you can fill out and add your information in there. So the link for that is in the chat, but it's a great just a resource to stick in your wallet. All right, I'll just give one more call for questions here. It looks like we have answered them all. All right, well, Dr. Abdelmalik, thank you so much for being here today.
Oh, my pleasure. Thank you for the invitation. It was great, and any feedback on the slides and the material, because like I said, I don't get a lot of opportunities to speak to the community in this way, and so it was a sort of great exercise for me to make sure that the science and the anatomy, the physiology is what I do. That's what I enjoy discussing, and that's what I talk to my residents about. But it's in order to distill it down so that it's useful for the community and particularly for patients is not sort of automatic. And so certainly happy to take that time to take this exercise and this opportunity to do that.
Well, thank you so much. It looks like there's a comment in the chat that it was a great presentation. So
thank you very much
for being here.
Thank you. You guys have a good day and enjoy the symposium. Bye-bye.
Thank you.